Hi, I'm Bob McMullen, and I wanted to tell you a case study of a patient who came in having an MI. Back in the early 90s, I was out in the middle of nowhere in West Texas in a little clinic 90 miles from the nearest hospital, and I was the only provider in town. I was both a paramedic and a PA at that point, and I had an LVN and a receptionist, and then there was another paramedic in town sometimes. It was a volunteer service, so you could never count on having more advanced life support. So one day I was working in the clinic, and the receptionist came back and said, "So-and-so is here, and I think you better come look at him right away." So she had put him back in the trauma room, which just meant the only room that had a stretcher that you could lay down in. And I went back, and it was our local preacher, and he was complaining of chest pain, and it was classic cardiac type chest pain. It was left side substernal, pressure radiating to his left arm and his jaw, made worse with exercise. Onset was at rest. He didn't have any history of problems. There were no associated signs or symptoms, no history of other problems. He denied diabetes, he denied hypertension, he had no other cardiac disease. He was taking no medications, wasn't allergic to anything. So I laid him down, did a physical exam. His lungs were clear, his mucous membranes were moist, he didn't have any pallor evident in his conjunctiva or his soft palate. His heart had a regular rate and rhythm, but it was a little slow. There were no murmurs, rubs, gallops. He had no tenderness in his abdomen. It was nice and soft. And his extremities were just fine. He was moving all extremities. He had no clubbing, cyanosis, or edema. So I put him on some oxygen by nasal cannula and pulled out our EKG machine, such as it was. This was one of the world's oldest EKG machines. We didn't quite have to put his legs into buckets of water, but almost. This was the version just beyond that. It really had one lead. It had three leads that you hooked up to get the white is right, smoke over fire, grass growing under the clouds, so the limb leads. But then it had one lead with a suction cup on it that you had to move through the locations for the precordial leads. And it only spit out rhythm strip paper. So you hook them up and you put the suction cup in the V1 position, and you have to go over to the machine and you have to run 6 seconds of lead 1, and then you move it to lead 2, then you have to move it to lead 3, and this is all just on the machine, a dial. So eventually you get V1, you get all the limb leads plus you get V1, then you have to go over and you have to move V1 to where V2 is and go choose V2 and get 6 seconds of that. So it takes about 10 minutes to do a 12 lead EKG. And then what you're left with is this 20-foot piece of rhythm strip paper that you then have to cut up and mount on these special little pieces of paper so that you could have your 12 lead. Well, it was obvious as soon as I ran his lead 2, lead 3 AVF that he was having an inferior STEMI. So started an IV, called the ambulance. The paramedic wasn't in town. The EMT they were called special skills at that point, wasn't in town. So we had to close the clinic, and the nurse and I jumped on the ambulance with this gentleman. I was hoping to I gave him some nitro, and that didn't seem to do much. Oh, I forgot to tell you his vitals. Blood pressure was 145/90 maybe. His heart rate was 60, and his respiratory rate was probably in the mid-20s and unlabored. The other thing on his EKG, besides the inferior STEMI, he had a sinus Brady / normal sinus rhythm right at about 60. There was no evidence of hypertrophy. I didn't see any QT prolongation, and no AV blocks or bundle branch blocks. So we have him in the ambulance now, and he's still having pretty significant pain. So I asked the nurse, do we still have morphine? I had just started there, and it turns out that the medical director for the ambulance who had been there, he actually wasn't there, he was in the town with the hospital, but he had allowed them to have morphine on the ambulance. But then when one of the paramedics left, the medical director said, you can't have the morphine anymore. So they had actually put the morphine into a safe deposit box at the bank because they didn't know what to do with it. So we actually stopped by the bank with this MI patient, and one of the EMTs ran in and got the morphine out of the safe deposit box and came back, and we gave him some morphine. He had a relatively uneventful trip, 90 miles up to the hospital. And when we got to the hospital and wheeled him into the ER, my supervising physician was there. She was covering the ER that day. So she said, why don't you stay and let's see what's going on with him. About that time, he went unconscious and he had no pulse. So we started CPR and hooked him up to the monitor, and he was in VFib. Greased up the pads at that point. Remember, this is the early 90s. Greased up the pads and defibrillated him. He immediately opened his eyes and became conscious again. And he was back in a sinus rhythm of some sort. So we took blood pressures, we did a decent 12 lead. Sure enough, he was having an inferior wall STEMI. And at this point, we were 3 hours by ambulance from the big medical center. And the helicopter would have to come from the big medical center down to us, pick him up, and take him back. So that's probably an hour at least round trip. What was happening at that point in time is we were allowed to thrombolyse people. We had TPA. This was before, which is alteplase. This was before the retiplase and tenecteplase came about. But the protocol, if you weren't a cardiologist, was that you had to fax the EKG to a cardiologist and have them agree with you that it's a STEMI and that you should thrombolyse the patient. So as we were doing that, he coded again, and we juiced up the paddles, shocked him out of VFib again, and this time he didn't regain consciousness. So he's in a normal rhythm, he's got a pulse, and he was unconscious, so I intubated him, and we started bagging him because he was apneic, even though he had a pulse. And we continued to monitor him. A little while later, he went back into VFib. And I don't remember, we had lidocaine hanging and all that kind of stuff. But he went back into VFib. We shocked him. He didn't come out. We shocked him again. I think we did CPR for a little while. The next time we shocked him, though, he came out of it and he opened his eyes. Now remember, he's intubated, so he can't talk. But he was conscious, so we sedated him a little bit and continued to watch him. I think the helicopter was on its way by this time, but he still was obviously pretty unstable. And he kept going back into VFib, and he would go unconscious, and we would shock him back into a sinus rhythm, and he would wake up and be conscious until he went back into VFib. this actually happened 17 times that we defibrillated him back to life out of VFib, and then he would go back into VFib. And it became kind of funny, if such a thing can be funny, because he would go unconscious, and we would look at the monitor and he'd be in VFib. And by that time, we were just holding the paddles because we knew he was going to go back into it. We would shock him, and he would wake right up in time to realize that whatever we were doing while he had his eyes closed was really hurting. At one point during the 17 defibrillations, he woke up enough to actually reach over and grab the doctor's hand. And the next time he went into VFib, before he lost consciousness, he heard us say, "Oh, he's in VFib again, let's defib." And he heard the doctor yelling, "No, he's holding my hand. Wait until I get my hand away from him." So he realized that as soon as he woke up, if he grabbed the nearest person, then we wouldn't shock him if he went out again. And so then we'd have to peel his hand off and shock him. And the other thing that happened was at one point he became conscious enough, he's still intubated, so he couldn't talk. And I hated to extubate him because he obviously was just so unstable going back and forth into VFib. At one point, he reached up and pointed at the pen in my pocket, and I handed it to him, and I gave him some paper, and he wrote, "Get this tube out of me." And so I spent some time in between defibrillations explaining that, well, I want to keep the tube in your airway. If it's not bothering you too much, I want to keep you intubated. And he got this look on his face. He reached over, grabbed the paper again, and he said, "Not that one, the one in my penis." Well, we had put a Foley in him, obviously, and he wasn't worried about the endotracheal tube. He was worried about the Foley. So then we had to explain to him, no, we're not going to take that out either. Well, to make a long story longer, and I will take the hit on this being more than 5 minutes, he did fine. He got, I think we hung TPA. I don't know if anybody's ever used that for an MI, but it's an initial bolus followed by a drip over 30 minutes, and then you have to give another drip over 30 minutes. Then you got to give heparin while you're doing it, and all of this. So all that got set up. He got in the helicopter and he left. And danged if a couple of weeks later he didn't show back up in town, come and see us, and he had done fine. He got cathed, I think, and he had quit the ministry and was leaving town to go to paramedic school. And sure enough, that's what he did, and then he didn't come back to town, so I don't know whatever happened to him, but he said that experience was so fascinating to him that he realized he could do more good by becoming a paramedic. So that's the end of my MI story, and I hope you enjoyed it.